This is Addiction Medicine Journal Club. I'm Dr. John Keenan.
And I'm Dr. Sonya Tredici.
We believe that addiction is a disease that can be treated, and we want to help you stay up to date with the latest research that you can use in your addiction medicine practice. The podcast offers Category 1 CME through MyCares and Michigan State University. The link to the CME are in the show notes. This week, we're going to be discussing my favorite topic, buprenorphine in pregnancy. How have you been doing, Sonya?
I've been doing really well. How are you, John?
I'm doing good. It's 9:42 on the day before Christmas Eve. And, I was dragging after a day in clinic and precepting, and I had a Red Bull before this, so I'm ready to go.
You're like never going to sleep. Do you have to work tomorrow?
Oh, yeah.
Hey, what are you doing for New Year's Eve?
I'm a 39-year-old man with young children. My New Year's Eve are boring. It's probably going to be like a Mario Kart party or something.
Bed by 9 o'clock?
Pretty much.
Mario Kart. I'm going
I'll
to stay
probably
up
go
till...
skiing.
That's awesome.
Yeah, this is like my favorite time of year with skiing, so I'll probably go skiing at some point.
I live in Gettysburg, and the big event in Gettysburg, I am actually going to stay up till midnight because I'm going to an event in town, which is the Thaddeus Stevens Lookalike Contest, where the winner will be announced at midnight.
Okay, well, this is life in South Central PA.
Yes, our staff musician, Dr. Benjamin Kennedy, has a gig at the local Lutheran church, and then we will be going to the Thaddeus Stevens Lookalike Contest.
Well, there you go.
So, John, on a more serious note, I read a really interesting but disturbing article about addiction this week that was in the New York Times, but about our area. It was about Baltimore and residential treatment in Baltimore. It was really, really disturbing. I'm going to put the link in the show notes, but basically they talked about some of these unregulated and overpriced residential treatment, like recovery houses, recovery apartments, places where people in recovery stay, and they, the state gets billed for counseling that never happens, and people are in this housing. And the reason it becomes so complicated, and I see this with my patients as well, is that your housing is then tied to your recovery and your compliance with the rules at the recovery house. So if the rules are, non-offensive, they're things like no drug use, because that's what the point of being in a sober house is, or, maybe you need to have a job or something. If they're rules that everybody agrees on, then great. If your housing is tied to those rules, it's not so offensive. But in some of these places, the housing was tied to compliance with, things that were actually unethical or people didn't want to participate in. But you have to, because otherwise you lose your housing. And everyone knows if you relapse on drugs, then immediately becoming homeless does not help you, do better. And so it was a little sad. And I thought about some of the situations my patients have been in kind of recovery housing, for better or for worse. Most of the places in our area seem pretty good and welcoming, more or less strict, but they do, usually people do okay there. But I have had some patients who really feel that they're a little bit, they're really beholden to the recovery house. They have nowhere else to go, and they lose some of their autonomy. I'll give an example. I have a patient who was on a 24 milligrams of buprenorphine a day dose, and the recovery house holds your medication so that there's no chance of it being stolen. But the person who ran the recovery house had such a work shift such that she would only dispense the medications to the people living there at 4 a.m. before she went to work. So you had to get up at 3 a.m. every day, and you had to take your entire 24 milligrams in a single dose. And that was your only option for getting your buprenorphine at, 4 a.m. Little stuff like that makes it hard. So I don't know, what's been your patient's experience living in local recovery houses?
I mean, my kind of city is of one, right? So I think that kind of locally here, I've heard mostly decent kind of recovery issues from most of my patients. They tell me that it's kind of worked for them. I've had several people, I live in York, Pennsylvania. I've had several people come to this area because of the strong recovery community that have no ties here. So I don't think it's been terrible. I do at times get triangulated into situations at the house, in the office, about a lost medication, or someone's on another medication that the house doesn't want to give them, and they don't think that that's right, and they want me to write a note or something along those lines. So those happen from time to time, but I've had positive experiences here. I think it's hard to regulate them though, right? And I think this is part of the problem, the same with the inpatient treatment centers and the long rehab stays is that you're getting variability here, and there is some for-profit groups that are profiteering off of these. They're not doing it for the right thing. They're doing it to make a buck.
Mhm. Yeah, totally, and there's money out there. There's a lot of money out there for treatment of opioid use disorder. So
Yeah, I mean, I'm not gonna say names. I was asked to interview to be a medical director for a recovery center, and it was a fair amount of money. And philosophically, I could tell very quickly from the interview that this just wasn't going to work. That like I was not going to see eye to eye with them. I remember like I felt kind of somewhat empowered. It was like the first time in my life that I was on a stage. I was like, I don't need the money. I'm not selling out. This isn't the nickel I'm selling out for.
yeah, interesting. Well, what about you? What have you seen in the news, recently that you wanna share?
And non-opioid related, this is from the New York Times, and I don't know what's going on with the New York Times, but there's a whole series of New York Times articles recently about alcohol use. And this article I thought was the most relevant of the three, but they were all kind of interesting. The other one's about kind of a new definition of drinking beyond binge drinking that some Americans participate in. But this one's about alcohol deaths having doubled in the past 2 decades. And the studies are showing that Americans are dying of illnesses related to alcohol at roughly twice the rate seen in 1999. And so the New York Times article talks about alcohol related deaths in the US have doubled from 19,356 in 1999 per year to 48,870 in 2022. That's a rising mortality rate of 10.7 to 21.6 deaths per 100,000 people per year. So that's kind of a pretty large increase for something that we know is very bad for our health. They talk about kind of large increases we're seeing kind of in adults age 25 to 34. That's kind of the largest rising group, but actually the group that has the highest increase of death is the 55 to 64 group. So kind of rising trends kind of in our kind of middle-aged adults or middle to late-aged adults, but also kind of our younger adults. They talk about how actually kind of deaths have increased across all racial groups, although kind of steep inclines with Asian Americans and Pacific Islanders and those in the Midwest are kind of more rural America once again. And they do talk about this marked increase after COVID-19. So I think that, I hear this a lot, like, COVID-19 is the reason that someone relapsed. COVID-19 is the reason that someone was destabilized. They were talking about just kind of general consumption patterns have increased during that period of time.
Mhm.
So I think it's interesting, and I also think we know that's bad for your liver health. We know it's bad for your mind and your memory, but I think there is increasing awareness from the general population about the risk of alcohol related to cardiac disease, but also cancer risk. Especially like breast cancer has an incredibly high association with alcohol consumption now. So I think as that information is disseminated, I'm optimistic that these will decrease a bit. But I thought it was interesting that it's a substance we've had for a long period of time. We know it's bad for you, and yet there seems to be a spike, especially kind of in our, you know, millennials and kind of late
Mhm.
millennials, that this is like something that's rising.
Well, and I don't wanna put you on the spot, you might not know this offhand, but what of all the different ways alcohol can kill you, did they say, like, any one particular way dominated? Like liver disease or accidents or the the
They didn't say one versus the other, although they did talk about kind of like a rising heart disease, liver disease, mental health illness,
Mhm.
which that's hard, like the mental health, like how are they quantifying that? But I think
Right.
there are associations with heavy drinking there as well.
Well, I'm glad that you're doing everything that you're doing to help treat alcohol use disorder. I know that's been a thing for you this whole year.
Yeah, it's hard because it's not like it's different than our other substances, right? I think that there's a like kind of abuse of that substance is somewhat normal for an age demographic, right? Like 18 to 25, kind of unhealthy drinking patterns are kind of a normal or societal norm there. It's kind of, we don't have another substance like that, right? There's no societal norm for cocaine use or meth use or
Mm.
injecting heroin or fentanyl. So it's kind of tough. It's a lot of mixed information.
Cannabis, that's kinda caught up.
Yeah, but still not the same. Like, it's not like you're watching football and you see like 15 cannabis commercials of like people like having a good time, totally unimpaired, enjoying company with each other. I don't know. I think it's not quite the same. There's still even states with legalized cannabis, right? It's not like you can just walk into any store and buy it like you can alcohol. It's still kind of limited to distribute areas of distribution. Some have home growth. I understand that, but I still think it's not quite as accessible or as accessible.
Well, it just doesn't have the long cultural history, that
Well, and
alcohol
also to be
does.
frank, I don't think it's quite as I mean, I think alcohol is more dangerous. I think that most studies would show that, right?
Mhm. It totally is. I mean, I can't tell you the last time someone actually told me they should drink because it's good for you. There used to be that sort of idea that 1 drink a day was good. That's pretty thoroughly died among my patients.
Yeah.
Yeah, I just don't know. I don't see as much alcohol drinking. Many of my patients are pretty abstinent. I don't have a lot of young people in my general practice who don't have opioid use disorder also. So,
I don't like this article mirrors like my younger patients. It's interesting. Like I'm family medicine, you're internal medicine. So I take care of like teenagers and young college kids. And like I have a large percentage of my college age students and high school students that don't consume alcohol at all. They just don't have a desire to do it. Much higher than I would expect. And I think they do tell me the truth. I find that they tell me lots of other stuff that I think they wouldn't tell me. So I don't know why they would hide that one from me. But a lot of my like 40-plus-year-olds, that's my group that probably has the most unhealthy drinking habit in my practice, at least. And I feel like it's a lot of people that work like, 9 to 5 jobs. Many of them are like construction or something manual. And then they go home and they drink, a large amount of alcohol per day. So I don't know. I think it's something about that age generation too.
yeah, yeah, I think so, and they don't have anything else to do in the evenings. It's okay if they're just home. Um, yeah, well, we'll keep on doing what we can do, right? Try to protect people.
Yep. So you want to tell us about this article tonight?
Oh my gosh, I totally do. This is a great article, and I feel like the more time I spent with it, the more I learned from it. So I'm really excited to share it with our listeners. So this is an article titled "A Pharmacologic Evaluation of Buprenorphine in Pregnancy and the Postpartum Period." It was published recently, September 2024, in the Journal of Addiction Medicine. So, for those of you who went to med school a really long time ago, I just want to remind you of two definitions. The first definition is the word pharmacokinetics, which is the movement or the kinetics and metabolism of drugs within the body. So, whether a drug is metabolized by the kidney or liver, how long it lasts, like what's its half life, those are the pharmacokinetics, how the drug moves around your body. The pharmacodynamics is the action of the drug on the body. So the dynamic action, what it does to you. So basically, what does the drug do over time? That's the pharmacodynamics. So just a reminder, pharmacokinetics is movement and pharmacodynamics is action. So buprenorphine is one of the first line treatments of opioid use disorder in pregnant people, along with methadone. And again, if you remember from med school, there are physiologic changes in pregnancy that may affect the pharmacokinetics of buprenorphine within the body. For instance, there's increased activity of buprenorphine primary metabolic enzymes, the cytochrome P453A, and also another enzyme called uridine diphosphoglucuronide, which is also has increased activity in pregnancy. So in pregnancy, you probably handle that buprenorphine differently. However, the package insert for buprenorphine does not say anything about different dosing in terms of total amount or frequency in pregnancy. It does address possible risk to the fetus and neonatal opioid withdrawal syndrome, but it doesn't say anything about the experience of the pregnant person. Again, implying that women are just vessels for carrying babies. They care about the baby, but they don't say anything about the mother, the pregnant woman. Um, Another thing you might have seen in practice, John, is that many patients report that sublingual buprenorphine seems to wear off after 8 to 12 hours. If you take buprenorphine sublingually, the mean time to maximum plasma concentration following that sublingual dose is variable. It ranges from 40 minutes to up to 3.5 hours till you get that max concentration. And then the level starts to decline, and patients can start to experience a kind of mild withdrawal syndrome. Um, keep in mind the terminal elimination half-life, like it leaves the body completely, is very long, from between 33 and 48 hours, depending on the report. So it really lasts a long time. And that's when you start to have serious withdrawal, shakes and vomiting and nausea and diarrhea, those kinds of significant symptoms. But this feeling of low key withdrawal that it's kind of wearing off in some patients can happen pretty quickly. And just with that thought, while total amount of buprenorphine could remain the same, split dosing may keep many patients at a more constant therapeutic blood level longer than a single large dose. So the authors of this paper observed that when patients were encouraged to choose their own dosing frequency, many pregnant people chose 3 or 4 times a day dosing rather than a daily or twice a day. And maybe they made those changes to maintain a more stable buprenorphine concentration for themselves. So before we go any further, do you tell your patients that there's any preferred schedule? Should they take their bup once a day, twice a day, 3 times a day? What do you tell people about dosing frequency?
Um, I think most of it's based upon kind of what I've been taught um, from other people that practice, but I often tell people for kind of addiction purposes or craving purposes, people tend to gravitate towards the twice per day dosing for convenience. They feel like it's kind of better for them. Oftentimes, when I'm dealing with people with acute on chronic pain, I'll switch it to 4 times a day since kind of the analgesic effects are kind of documented lasting shorter. So I've seen some pain management lectures where they've talked about, doing it, splitting the dose to 4 times per day might be more effective. So my post-operative pain patients, but typically one of those two are where I normally land. How about you?
Yeah, it depends on the total dose. Some of it's just ease of use. If you're taking 8 milligrams a day, it comes in an 8 milligram film. You can get a single film and just take it without having to cut and divide and bring it to work and all that stuff. I kind of let people choose what they want, but higher doses, 16 milligrams, I usually recommend twice a day. And then beyond that, I tell people they could do it 3 times a day if that works for them, or they could do it twice a day. And I really just let people choose. But I do, if they're starting to have withdrawal, I always recommend splitting the dose. So they would take like a midday dose if they're starting to feel unwell, kind of midway through their work day. The only dosing schedule I discourage is if I feel like people are taking it too frequently. Like I have people breaking their buprenorphine up into like 10 tiny pieces, and like every hour or two, they're taking more. And they're kind of spending all day saying, like, how do I feel? Do I feel a little, a little depressed, a little anxious? I'll take a little more then. So throughout the day, they'll have taken the full dose, but they've broken it up really frequently. And I discourage that just for sort of mental health reasons. Like, I don't want them to spend the whole day thinking about how much buprenorphine they need and do they need it now or can they wait half an hour? How many milligrams should they take? Or I want to kind of free their mind from that a little bit. Um,
Yeah.
so, all right. So, what's the clinical question here? This was a prospective cohort study, and it compared buprenorphine plasma pharmacokinetics during and after pregnancy, looking at the correlation between plasma buprenorphine levels, pupil diameter, cows, and craving score. So basically, how they set it up is they had people come into the lab, both pregnant people and then after birth, so no longer pregnant people. And they measured their buprenorphine levels and their pupil diameter, their cows, and the craving score before their first dose of the day, and then every few hours until they took their next dose. The point of this was to see how the buprenorphine levels rose and then fell throughout a single dosing interval, and what physiologic changes might then correlate with those fluctuating levels, and compare these numbers in both pregnant and non-pregnant people. So this is like the opposite of a giant cohort, database study. They had a small number of people, and those people stayed all day in the lab and got frequent blood draws and really careful monitoring. And they looked at their buprenorphine levels and then how it correlated with their physical and psychological symptoms. So, who is in this study? Population was 22 people, so 22 pregnant people. They were at the University of Pittsburgh, and they had to be on a stable dose of sublingual buprenorphine between 2 and 8 milligrams every 6 to 8 hours for at least a week. So, you didn't have to be on it for long, but at least somewhat stable. The only exclusion criteria was if you were using other opioids simultaneously. The demographics that this included 22 people with an average age of 29. 95% of them were white, 100% were tobacco smokers. average daily dose of buprenorphine was 13.2 milligrams a day in the first half of pregnancy, up to 17.7 in the second half, and stabilized at about 16 milligrams on average postpartum. So these are relatively young, white, tobacco smoking people in Pittsburgh. 22 of them were in this study. Exposure was plasma buprenorphine pharmacokinetics and pharmacodynamics during pregnancy, and then compared to the pharmacokinetics and pharmacodynamics after pregnancy. And the outcomes they looked at were plasma buprenorphine concentration throughout a dosing interval. So, like, you take your dose at 8 a.m., and then they measured your buprenorphine concentration every few hours and watched it go up and then watched it go back down again till the time of your next dose. And then they looked at these pharmacodynamic endpoints, which was pupil diameter, the clinical opioid withdrawal scale, and craving score. So, John, what did you think of the setup of this trial before we go any further?
It's really kind of interesting, right? Kind of very scientific compared to a lot of the kind of the population level data stuff that we normally do. I think yeah, it's really strong. It's very interesting. And I think it will give us some good information about kind of what's really going on with these dosing schedules for these groups.
Well, that's the most important thing about this trial in terms of, is it a good trial or not? It's small, it's just 22 people, but this is super important data on pharmacokinetics and pharmacodynamics in pregnant people. This is a unique data set. This data doesn't really exist, hasn't really been published before. And so if nothing else, it forms the basis for a larger study, but it's pretty good data.
Where
And
was
it's
this done at? Was this wasn't done in the United States, was it?
Oh yeah, Pittsburgh.
Oh, really? Pittsburgh?
Yep. Our neighbor to the west,
Okay.
University of Pittsburgh. So in terms of limitations, this study was smaller than they planned. They really tried to have more people in it, but they had some recruitment difficulties. And then they had some people who didn't adhere to the protocol. So basically, you were supposed to come into the lab not having taken your buprenorphine for the day, so they could get your first blood draw before you took your dose. And there were some people who didn't adhere to that instruction, so they weren't able to be in this study. You know, it's a very challenging study because they really are looking at these subtle symptoms of withdrawal that ended up being challenging. Like, people's withdrawal at the end of their dosing interval wasn't huge. It was pretty small, although it was definitely present. Um, it wasn't blinded, of course. And that could be a problem because some of the measures that they're looking at are subjective, especially in the cows, the clinical opioid withdrawal scale. And if it's not blinded, it's hard to know what to make of those subjective measures. Funding was unlikely to cause bias. But again, due to these limitations, despite these limitations, it's a really important data set. So I thought it was a valid trial. So let's talk about the results. Bottom line, pregnant people require higher dose of buprenorphine to achieve concentrations comparable to non-pregnant people. And then there's a temporal relationship between the plasma buprenorphine concentration and the pharmacodynamic markers of pupillary diameter, clinical opioid withdrawal scale, and craving score. So that's the bottom line. Pregnant people require higher doses of buprenorphine. So I'm going to get into the details here. First is the pharmacokinetic analysis. And this paper really is all about the figures. I recommend you go back and take a look. It's open access. You can click on the link in the show notes and really see these cool graphs that describe the data at one glance. In one glance, better than I ever could here, kind of trying to say it all out. But basically, as I said, pregnant women require higher doses to achieve the same plasma concentration. So in women who were pregnant compared to women who were not pregnant, those taking the same dose of buprenorphine had a lower plasma levels. And this was statistically significant with a p-value of 0.036 when they were compared. Basically, after an initial dose of buprenorphine, identical doses will give a 29% lower plasma concentration in a pregnant than a non-pregnant person. And this effect is even larger during the second half of pregnancy, where plasma concentration is approximately 45% lower than it is in the postpartum period for an identical dose of buprenorphine. So in this study, they subdivided pregnant into first half and second half of pregnancy. And the difference between pregnant and postpartum buprenorphine levels were only statistically significant between the second half of pregnancy and the postpartum period. So that second half of pregnancy difference is what really drove the overall difference in pregnancy. The p-value was 0.014 when comparing the two. Um, the difference in buprenorphine concentration between the first half of pregnancy and the postpartum period was not statistically significant. So it's that second half of pregnancy where you really saw the change. So that's result 1. Result 2 is the pharmacodynamic analysis. Um, and again, take a look at the figures in the paper to really understand them. But the authors looked at the COWS, the clinical opioid withdrawal score, pupillary diameter, and craving score as the buprenorphine levels fluctuated in those patients. And this is where it would be awesome to have it be blinded, but it was not blinded. So both cravings and COWS scores changed synchronously with buprenorphine concentration and pupillary diameter. So these data really demonstrate the close relationship between the pupil diameter, the COWS, and the craving scores to that plasma buprenorphine concentration. So what you see is as concentration goes down, those scores go up. Um, and it happens consistently in all the people at all the times. Another thing that they found was that the average plasma concentration was about 1 nanogram per milliliter, and that's the concentration needed to achieve low levels of withdrawal and low levels of craving. So for pregnant people, about 1 nanogram per milliliter was the minimum plasma concentration they needed to stick at. And then basically as buprenorphine concentration approached that 1 nanogram per milliliter level, the pupillary diameter, COWS, and craving scores went back to baseline. So, John, do these results surprise you? Are they expected? Is that what you would have expected in this population?
You know what? And when you're going through the changes between the first and second half of pregnancy, I was trying to think through like the change in physiology of like of distribution. And to be quite frank, I'm not 100% sure if that's what I expected at all. It kind of does anecdotally, I feel like reflect what I do see though. I mean, it normally starts out fine on current treatment, and then as pregnancy progresses, typically towards the second half, that is typically when people seem to struggle a little bit more. And I often find myself doing dose changes.
Yeah, and I don't know about the enzymatic activity in pregnancy when if those cytochrome P450 enzymes are when they would be more active, but I certainly having experienced pregnancy, like those physical changes are a lot in the second half. And you can get, especially if it's like your first pregnancy, you can get pretty far along and you really don't look a lot different or feel a lot different, for 3, 4, 5 months, and then it really hits you. So, yeah, I guess what I was surprised, and maybe this is just me, like, not believing my patients. It sort of laid it out in black and white when people say the buprenorphine's wearing off. What's really going on? Like, it really is wearing off, and they really are experiencing withdrawal at, like, 6 hours, 8 hours after their dose. And I never knew what to make of that because in my mind, I'm, like, thinking of this drug has this super long terminal half-life, you know, in some studies up to 48 hours. I'm like, "How is it wearing off at 6 hours?" Um, but it really
You know,
is.
it is interesting when we cover these like serum concentration articles because we've had other of these in the past about like correlating like what level, like how long the drug's in your system, and then kind of what level of receptor saturation do you need for withdrawal. And then it's a whole nother level for kind of cravings and subjective feelings of kind of drug wanting attainment. So I feel like it kind of makes sense, right? I feel like it's always higher than what we think it is to actually achieve the result that we want than kind of
Mhm.
by the book answer with the pharmacokinetics.
I ran into this issue many years ago when we were first starting to try to use buprenorphine in the hospital, and I remember I had to have a bunch of conversations with people that it's not like benzodiazepine for alcohol withdrawal. You can't dose the buprenorphine to just treat physical withdrawal, and then when physical withdrawal is gone, you're done with your dose. Like, the dose like, the withdrawal is just gonna go away anyway, and then so the people were being discharged from the hospital on, like, 2 milligrams, 4 milligrams a day because that's what took care of their withdrawal. But it didn't help their cravings, and it didn't help them stay, drug-free after discharge. So, right, you need these different levels to achieve different outcomes. It's not all one. So will these results help me in patient care? I definitely think they will. They emphasize that dosing of pregnant people should not be based on studies from non-pregnant people. That's thing one. Number two, these current doses, 8 to 16 milligrams, have been criticized as too low. And we've seen that in some recent papers that we presented on buprenorphine dosing in the time of fentanyl. Calls for higher dosing recommendations in pregnancy have been based on clinical outcomes like retention and treatment rather than on pharmacologic studies. So, this pharmacologic data adds significantly to the literature and to the evidence calling for higher doses of buprenorphine in pregnancy. Another thing that I'll definitely use is that a single daily dose in many pregnant people will not maintain their plasma concentrations above the minimum threshold of about 1 nanogram per milliliter. So, even if they're taking a constant dose, splitting it into 2 or 3 or 4 times a day will give them more time at that therapeutic plasma concentration. So basically, I'll be telling my pregnant patients that they definitely may, if they want, they can try splitting their dose to 3 or 4 times a day, their preference if they'd like to. And I'll check in throughout pregnancy, especially in the second half of pregnancy, about symptoms of craving and withdrawal because they're relatively subtle. And then if you're pregnant, something like fatigue or having hot flashes or, I don't know, feeling anxious or depressed or achy, you might just attribute those to pregnancy. And I might just proactively bring it up with people and say, are they having these symptoms at the end of their buprenorphine dosing interval? And if so, do we need to increase the dose or split the dosing? So for me, this will definitely change my counseling for pregnant women. Before I kind of let them bring it up, I'd say, "How you doing?" They say, "Fine." I'd kinda leave it there. I wouldn't push a little on how they're feeling. So I think this will change my practice. How about you, John? Do you think that this will change what you do for pregnant patients?
Mm, I don't. To be quite frank, I feel like for a long time, I feel like I've kind of expected dosage adjustments with pregnancy, but I've kind of let patients guide me to it. So I think it makes me feel better about it. Like I believe them. I do think that they're struggling as the pregnancy goes on. And to be honest with you, I've thought before, I'm like, is this really kind of a pharmacokinetics issue, or is it just that kind of it sucks to be pregnant at 32 weeks and that it's just emotionally more taxing, they have more cravings, and that's what it's helping with? Either way, I don't really care, but it probably is related to the distribution here, as you're talking about, and it probably does have more of a physiological basis than kind of an emotional basis.
Yeah, I think this paper, it's pretty technical, it involved a lot of blood draws. It's not a super sexy topic, it hasn't been cited in a million news articles, but I think it's gonna be a foundational paper as people develop, newer guidelines, updating guidelines for treating opioid use disorder in pregnancy. So, yeah, I'm glad we got to talk about it.
Well, I really appreciate you kind of presenting that article. We don't have any talk back this week, but thank you for listening to Addiction Medicine Journal Club. The best part of any journal club is the conversation, and we want to hear what you have to say. To have your opinions about the articles included in a future episode, send us your comments on social media, email, or join our Facebook group. The links are in the show notes. Original theme music was composed and performed by Benjamin Kennedy, audio editing by Michael Bonanno. CME support from My Care is produced by Dr. Patrick Beeman and Ars Longa Media. Addiction Medicine Journal Club is intended for educational purposes only and should not be considered medical advice. The views expressed here are our own and do not necessarily reflect those of our employer or the authors of the articles we review. All patient information has been modified to protect their identities. Thank you for being part of the conversation and have a great day.